And good morning and welcome to Health Talk right here on AM 1270 and 96.5 FM KXVX. I'm Paul Thomas, and in the studio with me, as always, is Bill Kearney of Northlake Medical Pharmacies. How are we doing today, Bill?
We're doing good, and like, what's his name, Steve Harvey, we have a good one for you today.
Yeah, there you go, the Family Feud, right?
Yeah. Got a lot of new stuff to talk about, and had the presidential conference or presentation last night to Congress, and I thought that went rather well for health care. And a lot of people will disagree with me, but I think health care is very much damaged and needs to be repaired. And no matter what side of the aisle you're on, even though the one side of the aisle put a hands down about any kind of a change, I think we have to have a change, and we're looking forward to having something a little bit more substantial in healthcare that people can afford, and hopefully that's going to happen. We have expectations, just as like everyone has, about whether or not the changes that Trump's policies will impact pharmacies. And one of the things I heard him speak about last night was for every new regulation in the government, there will be 2 regulations taken away. And I happen to know somebody that works for NOAA, which is North Oceanic Atmospheric Administration, and in Washington, D.C., and he was asked to cut 2 regulations, and he said, "Are you kidding? That's, I could cut 30 without even looking at them." So that will help. We just passed the first 100 days of administration, and we're looking for Affordable Act reform, which will help patients as well as benefactors. In addition, an oversight for the pharmacy benefit managers has been talked about and already instituted in some form, and these are the people that control the price on your prescriptions. So they are taking a lot of extra funds away from the providers and also from the patients, and that is going to be limited due to the Medicare ruling that was put into effect a couple of years ago. And then lower prices by drug manufacturers. We still have these isolated instances of them raising their prices astronomically, and those will be addressed one by one as things go. And the thing that pharmacy is trying to get really clarified is the fees that go to the pharmacy benefit managers, and have some transparency when we fill prescriptions. Every day we tell somebody we can't afford to fill the prescriptions because the pharmacy benefit managers are taking the money and we are losing money by filling the prescriptions. And that should not be happening. It shouldn't be legal. It should be prohibited. And what happens is, after we fill the prescriptions, we have to wait sometimes 2 months. When we fill the prescription online, it will tell us how much money that we made, whether it's an $8,000 prescription and we made $400. And we assume that's okay, even though none of you who would be in business would sell something for $800 or $8,000 and make a couple of $100. We have to do that according to the law. So, and then 2 months from then, or 30 days from then, we get a directive from the pharmacy benefit manager saying, we charged you back $1,500 for that prescription. And it makes no sense whatsoever. At least we want to have transparency when we fill those prescriptions and know exactly what we're going to make or lose, and have the option to fill those prescriptions or reject those prescriptions. So if we can get some of those things changed, and you think that maybe we're overreacting, not really when it comes to trying to run a business and trying to get you prescriptions that we can afford to dispense to you, and they can afford to give you. So we're hopefully looking at good changes. Our number is 263-5252 if you have any questions about your health. One of the things that was mentioned last night, Paul, was bringing newer drugs to the market without having delays. And that can be a good thing, and that can be a bad thing. When you come into the pharmacy to get a prescription, and you're not very ill, so I mean that's debatable, I'm sure, by your psychiatrist. But
I do take 2 medications now daily.
So yeah, that will increase.
That'll increase over my life, I'm sure. Yeah.
And we are obligated to tell you when you get a prescription the side effects of that medication, what can happen, what's an unexpected side effect of that medication. As we get approvals for drugs faster and faster to come on the market, you've heard me say that I'm a fan of big studies. I like double-blind studies with thousands of people in them. They're going to start approving drugs with 1 or 2 studies of not large quantities, because they want to accelerate bringing drugs into the market that can help diseases, but also they could be very dangerous for your health. Now, they have what they call a black box warning that tells you what we need to tell you as a patient on some of the medications that can be more harmful than helpful, and we'd go through this risk versus benefit thing. 99 times out of 100, people don't listen to us. I just had a patient, a very good patient of ours, come in yesterday and had a prescription for prednisone. Prednisone is a non-steroidal, or it's a steroidal anti-inflammatory that does very well to help people breathe. They get bronchitis and they get bronchial constriction, so they're not getting air into their lungs. This opens their lungs up. You can take it for poison oak or poison ivy. You can take it for many kinds of reactions. But one of the side effects that you can get from taking cortisone-type preparations is an anxiety. And I was telling this patient about law enforcement. When they get into, especially the task force, when they get into poison oak and poison ivy, and the physician puts them on what we call a dose pack, they're carrying a weapon around. They're designed to protect us, and I will caution them at the time. You may get a little more irritated when you're taking this steroid, so just be aware of that as law enforcement. It isn't just law enforcement; it's any of us, but we're not all carrying around a weapon to protect you from the other elements. So, and that doesn't happen to everybody. It's just a possibility that it can happen, and you need to know when you're taking this medication. If your wife doesn't tell you that you've gotten a little ornery lately, and I know, Paul, yours would never tell you that. Is that correct?
She'll tell me. Trust me.
She
will. Yeah. She'll tell me I'm being that way even when I'm not.
Yeah.
just to keep me in check, keep me guessing.
So when we go and bring new drugs to the market at an accelerated rate, we're going to bring them on at a risk to you, the patient. And we have said to you many times, this new era of healthcare is you have to be responsible for your care. And when you get a prescription, you need to ask questions on why you're getting it, what the meds might do, what they might be, why you're taking it, how long are you going to take it. We've gone through this drill several times, but it's something that you need to know that it's for your benefit, and you need to be aware of it. Now we're going to talk about a few new drugs and some of the things that you get when you go into the hospital, and it's not necessarily a hospital's fault. It is the fact that you have a lot of bacteria around you. And despite the awareness of the risks of broad-spectrum antibiotics, a lot of them continue to be prescribed when they're not necessarily predictable at that time. And many times we have to wait until we get a test to find out what bacteria that you're having a problem with, and then get an antibiotic to make sure that you get the right drug for the right infection. And while there's programs out there to monitor the antibiotic use in hospitals, those are mandatory in Britain, and they're trying to catch up. The Joint Commission is in the United States. But what we really need are national policies requiring hospitals not only to have these kind of stewardship programs, but also inform the public about how well their doctors are following these guidelines. So when I tell you to ask questions, a lot of that is about an antibiotic when you're getting it. What is it for? If your doctor suspects a bacterial infection, can you be tested for it? Would results confirm the infection and determine the type of bugs there so you get the right antibiotic? Is it a narrow spectrum or a wide spectrum antibiotic? And too often we use the wide spectrum antibiotic, which covers all kinds of infections, just to shotgun the approach so we don't have to see you again. And narrower drugs like penicillin and amoxicillin usually are a better choice than the broad spectrum drug. But typically we get a quinolone like floxacillin or ciprofloxacin or something like that that covers a majority of types of bacteria, and all this bacteria develops up a resistance or a standard. How long should we take it? And we've talked about this a lot lately, because there are some things that are changing on taking antibiotics for a specific amount of time. Ask your doctor to prescribe it for the shortest time possible. That's why we see a lot of Z-Paks, azithromycin, because you take 2 pills one day and 1 a day for the next 4 days, and you're done. One common mistake that doctors make is not switching from a broad-spectrum antibiotic to a more narrowly targeted antibiotic once the bug has been determined. So, and side effects. Most antibiotics are well tolerated, but there are some that aren't. For C. diff, for example, is this constant diarrhea. You're taking sometimes 2 different antibiotics. One has a very metallic taste to it and can be very uncomfortable to take, and the other one needs to be taken with food, and you need to know that when you take those antibiotics. So just to remind you that going into a hospital can cause, not because the hospital's not good or anything else, but it could be a problem when you're having a hard time beating off an infection and you're exposed to different bacteria than you go in there for. You've heard a lot on the news lately about flu vaccines, about not being effective, and it's worse in Europe than it is here. The current flu vaccine is about so-so. About half the people from that get the shot have deterred the infection. That's not as good as last year's formula, but it's better than in some past years. And the effectiveness indicate that the vaccination or the vaccine reduced the risk for influenza by about half, and it lowered the risk of having to go to the hospital or the emergency room by about 48%. So there's actually a half a dozen different flu vaccines that are formulated differently, and this includes all of them. So taken together, they provide a 43% protection against H3N2 viruses and a 73% against influenza B. What's happened is that vaccine has mutated as it's got farther west, and we need to know a little more accurately what happens when this thing mutates. It's been a moderate flu season so far, but as it gets farther west, it's going to last longer than we thought. Elevated flu is going to probably last for several more weeks. It spreads every year because those viruses mutate. In any given season, the different strains will circulate, and it's what we call drift, and that means they'll change a little. They'll mutate a little from one month to the next. And the longer it goes, the more the mutation goes. So that's why fresh flu cocktails are needed every year. In addition, the vaccine protects people for only a few months after it's given. And we haven't heard this before. We were told to vaccinate early, and now they're telling us to wait until, because this flu has gone on longer than usual, is to wait until October, November. I don't know, a team that tested flu patients with other illnesses in 12 countries found that vaccines protected people from infection about 38% of the time, and it was least effective among the sick and elderly people, and those are the ones who have a difficult time surviving many times. So I still recommend that everybody get a flu shot every year. If you can eliminate the cost and the problem of getting the flu by 50%, that's about as good as it gets in something that changes that frequently. So just remind yourself that, and I kind of have to talk patients into this every year. I still immunize all my patients and my family, and I think if there was any other disease, for example, cancer, if you had a chance of eliminating cancer by 50%, would you get an immunization? Of course you would. Diabetes, of course you would. We're being proactive as far as the flu vaccine. It's going to change. It's going to get better. And all we can do is support that growth. It doesn't cost you anything to get that shot. So we're encouraging you to do so. This year, they've already pulled it back off the market. Really, at the end of January, they call it all back in because it's only good up to April. And if you get it in April, there's a little time for you to build up immunity, and then by the time the flu season starts again, that drug isn't active enough to stop you from getting the flu. So 263-5252, we've got a new drug to talk to you about that has to do with migraines. And although it's not available right now, it is one of the hottest things that we've seen to stop migraines before they start. There is a patient started a study in Santa Monica, and Dr. David Kudrow has enrolled in one of his clinical trials for people with headache disorders. And he's one of hundreds of doctors investing and investigating in a new class of drugs that block calcitonin gene-related peptide. That's CGRP. It's a molecule that elevates or spikes during a migraine attack, and the aim of the medication is to stop the migraine before it ever starts. If they can block this peptide, this gene, then you can abort a migraine attack. It's not a pill, it's an injection that stays in the system for a long period of time and is continually blocking that mechanism of the migraine. So results from several pharmaceutical trials are expected even later this year or in early 2018. If approved by the Food and Drug Administration, it would be available in 2018. Now here's the kicker. The price tag could be as much as $10,000 a year. Now, this is a drug that's known as a CGRP. I don't expect you to remember it's a calcitonin-related peptide that has to do with a form of protein, but it's a molecule that spikes during a migraine attack and stops a migraine before it starts. More than 35 million people suffer from migraine attacks. About 4 million sufferers have chronic migraine, and that means they have a headache every 10 to 14 days a month. Most of them are benign. They can be very disabling. People can have to be in rooms that are dark and no artificial light, no light at all. Some people are helped by over-the-counter medications like anti-inflammatories, like ibuprofen. Others need prescription medications that may cause side effects such as dizziness. So if there's a reduction in the frequency and intensity of headaches for a large number of patients taking the new class of drugs, excuse me, but not all, it should lead to a decrease in the amount of medications used by patients to handle headaches acutely. So These people receive regular injections once a month for the past several months and now experience only 1 to 2 migraines a month. They feel like a different person who no longer has to shy away from social commitments. And I've never had a migraine headache, but it's life-changing for many, many people. I've had employees, especially when I worked for Walgreens down in the Bay Area, I had 2 employees that had cluster headaches, and it would completely immobilize them for 2 or 3 days. These kind of headaches, and I assume, and I don't even know the name of the drug, that you get them prophylactically every month to help you from having a migraine occur. And again, it's not 100%. They still get 1 or 2 migraines a month, but compared to 1 every other day, substantial improvement. That idea that you can go through life and not have that be an issue when it's been an issue all your life is just an incredible achievement when it comes to medication. I don't know what the side effects are. I don't know what the risks are. There's always that risk versus benefit that we've talked about when you bring new drugs on the market. There obviously are side effects that can occur, and you as a patient, we're less than a year away now of this drug making it to market, especially with the new policy on bringing new medications to market. So it will be something that you'll have to look at and try to investigate as a patient, especially if you're one patient that gets these. I have several patients that get multiple types of medications for migraine headaches, and some of them end up going into the hospital, into the emergency room, for a Demerol injection on top of that. So this would be highly regarded. Again, we see they're pricing the medication for what good it's going to do, not what the cost of the medication is. So as we see more and more of that go on, it becomes harder and harder to control the prices. That raises the insurance cost up, that raises the premiums up, that raises the copay up, but that's the cost, the new cost of providing health care in America. We're going to take a break, and when we come back, we're going to talk about your heartburn medications and how that might be damaging your kidneys. Hi, my name is Bill Kearney, pharmacist and owner of North Lake Medical Pharmacies. I want to tell you a story of the transition of North Lake Medical Pharmacies. 37 years ago, we left the Bay Area to begin our life as part of Lake County. We opened our first pharmacy across the street from Lakeside Community Hospital. Our mission was to bring affordable prescriptions to the patients of Lake County, as well as free delivery service, charge accounts, service to all 3 skilled nursing centers, and hospice. 15 years later, we had outgrown the pharmacy and opened the second pharmacy in Bruno's in Lakeport. In 2010, we moved our pharmacy outside to a freestanding pharmacy. We began the transition to more of a retail population and began including other services. We now do immunizations and sell more durable medical equipment. We also sell diabetic shoes and lift chairs. Our store is focused on you, the patient. We know you have choices when you need prescriptions, and we appreciate you making us that choice. North Lake Medical Pharmacies with 2 locations, across from Sutter Lakeside Hospital and outside the Bruno's Shop Smart.
Hi, I'm Mia Hamm. As a professional soccer player and a future soccer mom, I know how fun and rewarding sports can be. I also know how frustrating it is when you're sidelined by an injury. So I've teamed up with the American Association of Orthodontists to ask young athletes to play it safe when playing sports. I spent years training to become a world-class athlete. I know what it takes to become an expert on the field. Orthodontists understand this too. They're experts in their field, helping kids and adults obtain healthy, beautiful smiles. They want to help athletes prevent injuries and stay in the game. It only takes a second to get hurt, and too many athletes are risking injury because they're not properly equipped during games and practices. Wear the right protective gear, like mouth guards, face masks, and helmets. Your first line of defense against preventable injuries. Play it safe, achieve your goals, and keep smiling. Visit braces.org.
Deep within the Pest Quest training laboratories.
Stinging insects send over 500,000 people to the hospital every year. I don't like hospitals. Rodents, like mice, contaminate food and transmit disease. Cockroaches spread 33 kinds of bacteria, 6 parasitic worms, and can trigger asthma. That can't be good.
Pests are anything but child's play. Protect your little scientist by getting the facts at pestworld.org.
A public service message from the National Pest Management Association.
For nearly every woman, there's a moment.
My name is Alyssa.
A moment when she realizes, despite all the progress that's been made, barriers still exist for women and girls.
My employers thought it was nice that I had an advanced degree in addition to my work experience, but they weren't willing to pay me for it.
For Alyssa, a wife and working mother of 2, her moment came after reading an article on pay inequity.
In that moment, I knew I had to do more for myself, my family, and for other women.
Alyssa became a member of AAUW.
In joining AAUW, I want to help pave the way for my daughter and young women whose futures aren't yet defined by boundaries.
Join us in breaking through barriers for women and girls. Visit aauw.org to find out how and to connect with an AAUW branch in your community.
All right, we're back.
All right, Paul, everybody has heartburn, right?
I certainly do.
And there's certain kinds of medication. In the old days, we took Rolaids and Tums, and that helped right away, Maalox and Mylanta. Then it became what we call H2 blockers, and it was Tagamet and Pepcid and Zantac. And those helped some to block the acid. And then we came up with PPIs. And those are protein pump inhibitors, and you and I and a great majority of people around the world take those for acid reflux. Mm-hmm. But if you pop heartburn meds like their dinner mints, you may be doing your body more harm than just stopping the chest pain. The proton pump inhibitors are the most common prescription for managing acid reflux, and that's what most of us take. And we've talked many times about the people taking medications for acid reflux. A lot of it would have to do with changing their diet, which they don't want to do, or the time of day they eat. But this one kind of alarmed me, and I put a big star on this because I want to caution our listeners about taking this too seriously. And I'm one of the patients that are on these medications, but this study just came out in February. Last month in the Kidney International, researchers found that more than half of 125,000 patients in the United States who took PPIs developed chronic kidney disease without showing any acute kidney problems beforehand. And that's the part that got a message to me. It's not that lack of advance warning was both new and the most worrisome, but traditionally when you take these drugs like Nexium and Prevacid and Protonix, and your doctor monitors you for kidney injury, which is kind of a flash flood version of chronic kidney disease, which is a sudden episode of kidney failure or damage that occurs within a few hours or days of the trigger. If you exhibit early warning signs, which would be decreased urination or nausea, swelling in the legs, ankles, or your feet, you would take yourself to the doctor, and the doctor would probably take you off those drugs that have triggered the problem. And that sounds like a smooth plan, right? But the latest study suggests that these users might not actually have the warning signs before going into full-blown kidney disease. They essentially skip the rainstorm and are dropped straight into the damaging flood. And it's no secret that PPIs are linked to kidney damage, and it has been for some years. But they did a study of Johns Hopkins University and found people who took PPIs were 20 to 50% more likely to develop chronic kidney disease than those who didn't. And another November 15 study from the New York University at Buffalo found 25% of patients who developed chronic kidney disease used PPIs. Now, as we said in the beginning, there's 3 types of heartburn medications, and it's certainly not just PPIs that cause the damage. But a new study did find that people using those were about 20% more likely to develop chronic kidney disease compared to those taking H2 blockers such as Zantac and Pepcid, and the first one we talked about. So as it's not just your kidneys that are at risk, this study in January 2017 linked moms-to-be taking any kind of heartburn medicine. That's either the PPIs or the H2s or antacids with an increased risk of their children developing asthma. And then a 2016 study found that folks over 75 years old who took PPIs were 44% more likely to develop dementia compared to those not on the heartburn medication. And to top that off, they found that people taking long-term PPIs had a higher risk of cardiovascular disease. And these things all, they're scary because with the new information we bring these things to you, and all these studies prove a link between the medication and the disease, but they don't prove cause and effect. So doctors do recommend trying to avoid the cause of heartburn. That includes spicy food, alcohol, citrus, coffee, tomatoes, peppermint, and then still, if you need an acid reducer, talked about PPIs or Pepcid or Tagamet or Zantac, or Tums or Rolaids or Maalox or Mylanta. All I'm trying to do is bring this, and again, the thing that scared me about all this as being, I was put on PPIs back when I was diagnosed with colon cancer, which we're going to talk about in a minute, and that was 13 years ago because of the extreme acidity in my gastrointestinal system, in my stomach and intestines, which is a media to grow carcinogens or cancer-causing cells. I was advised to take this the rest of my life. The thing that disturbs me is that this chronic kidney disease could come on instantly, and there would be no warning, and you're dropped straight into having that problem. This is one study. I don't know how big the study was. I'm probably not going to change what I do. I have an appointment with my doctor tomorrow, and I'm going to talk to him about it and see what he says. And maybe I will attempt to taper off the proton pump inhibitor and maybe see if I really need it or not anymore. I would hate to find out that the result of that was my colon cancer coming back. And then it's not just a simple process at my age to cut the polyps out and not have it spread anymore. So it's not that your kidneys are at risk that we know about, and we certainly, I hesitated to bring this up because I don't know how big the study was. I don't know how many people were involved in it. I don't know if it was a double-blind study. But the statistics are rather large for it being a problem. But this is why I had a little disagreement with the president's message last night that we didn't need these huge studies, that we can do a fewer amount of the population to decide what the risks of having a drug on the market and bring it on the market. And when that happens, then you have to be the person that's at risk here. Less thoroughly tested drugs and medical implants might reach the market, and essentially people getting new treatments will become experimental objects. This isn't a new treatment. This is one that's been on for a long time. So going forward, consumers will need to especially be careful when you have a choice. Consider treatments with a proven track record. It isn't that these drugs haven't been proven to be effective at lowering gastric acidity and the pH level in your intestinal tract and your esophagus. It's not that they don't work. It's what is the risk of them working. And again, When you take a study like this and you don't know what the population is, even if you knew there were thousands of people taking this test, how many of those were smokers? How many of those were alcohol drinkers? How many of those had other disease states? There are many things that, like I said, this is a link. It's not a cause and effect. So, like I said, I'm not going to change anything. But who knows? I've not heard of this in the pharmacy, but it could be happening. So we need to, my job here is to make you aware, not to change your physician's prescribing, not to change how you live your life other than diet and exercise, but just make you aware that this is in the literature as being a risk, not a cause, but a risk when you're tied up with a proton pump inhibitor. So that's my job to report to you what those are. Now, yesterday we heard on all the national news media about colorectal cancer rising sharply amongst Gen X and millennials. The rates of colorectal cancer, which overall have been declining for decades, are now rising sharply among young and middle-aged adults. And that started researchers looking about whether screening should start earlier than age 50. I just talked to a person the other day that was 87 years old and having some gastrointestinal problems and had never had a colonoscopy. And his physician had told him that he didn't need to have a colonoscopy. He was 87 years old. My suggestion was if you continue to have some of these gastrointestinal issues, then why not have a colonoscopy? If you're 87 years old, you're doing pretty good. So this study was just published yesterday in the Journal of National Cancer Institute, found that between 1980 and 2013, colon cancer rates increased from 1 to 2% per year for people in their 20s and 30s, and rates for middle-aged adults also rose, but at a lower pace. Rectal cancer rates climbed even faster at about 3% per year for people in their 20s and 30s, and 2% annually for those aged 40 to 54. So as a result, 3 in 10 new cases of rectal cancer now are diagnosed in patients younger than 55, double the proportion in 1990. And by contrast, the rectal cancer rates in adults 55 and older have dropped in 4 decades. So the American Cancer Society actually led the study that earlier work had signaled a growing incidence of colorectal cancer among Gen X and millennials. But the magnitude of increase has intensified, and it was just very shocking to the medical profession. And the underlying risk appears to be rising. This included scientists at the National Institute of Health and determined the reason for the shift, but suggested one might be a complex reaction involving the same factors that have contributed to the obesity epidemic: changes in diet, a sedentary lifestyle, excess weight, and low fiber consumption. This colorectal cancer refers to malignancies in the colon or rectum, which are part of the large intestine. Most of them start as polyps or growths. Most are benign, but over time they can develop into cancer. It was 13 years ago. I was, 63 years old, and mine had already developed into colon cancer. And there's almost 40,000 new cases of colorectal cancer that will be diagnosed in 2017, and about 50,000 are expected to die just in the United States this year from colorectal cancer. And this latest research, unlike the other one, looked at more than 490,000 people ages 20 and older who received diagnosis of invasive colorectal cancer between 1974 and 2013, with a specific focus on years of birth and a 5-year age group that separated them. It found that people born around 1990, doesn't even come close to when I was born, have doubled the risk of colorectal cancer and quadrupled the risk of rectal cancer of people born around 1950. Now you're getting closer. The incidence of Americans age 55 and younger with colorectal cancer doubled between 1989 and 2013, and now accounts for nearly a third of all the cases. The rate increase among adults in 20s, which actually began in the mid-70s, has been particularly fast. It is something that I can tell you that you don't want to go through if you can avoid it. When you get that diagnosis, and many of you that are listeners have had the diagnosis of cancer before, your life changes immediately. You start thinking, I'll never forget, I kept thinking, this is my last Father's Day that I will have with my kids, and that didn't happen. But you start, this monkey brain we have starts saying to you all kinds of crazy things about not being able to survive. And I think the younger you are, the more that occurs, because you're right in the middle of raising a family. They are majority of young people aren't going to get colorectal cancer, and their symptoms are most likely not the disease. But it's still critical that young people who do have symptoms, which includes rectal bleeding, and that's exactly what happened to me, push their doctors, and if the problem doesn't resolve, you must ask them or tell them exactly the symptoms you're having. Young people are often diagnosed at a later stage because, unlike older Americans, they aren't getting screened, and doctors don't necessarily suspect cancer. I have an individual that comes to my store about every 2 or 3 months and takes lab tests, has tests for diabetes, tests for bone density, tests for LDL, HDL. This March the 18th is going to be his last trip up here because people aren't getting those tests anymore. And it's kind of sad with the millennials and the Gen X generation that are expecting instant results from what they're doing, and they get the results instantly when they come into our pharmacy to get the lab tests. And I'm not saying don't go to the hospital or don't go to a lab place to get a lab test, but this individual has been doing it for my pharmacies for several years, and he said it's just, and he comes up from Southern California, he says it just isn't cost effective anymore because there aren't that many people that are getting the tests. I would hope that through your health practitioner or your physician, you do get those tests. We do need a new analysis to see if we should start screening earlier for colorectal cancer, although that's not one that we can do. The rates are increasing for people in their early 50s, but decreasing for those in their late 50s. And the younger group's rate used to be half of that of the older group. Now it's just 12% lower. So it's something that weighs heavily on my mind because of my diagnosis many years ago, and it's something that saved my life. In fact, I had 2 colonoscopies, and the first one it didn't show up. The next one, a month or 2 later, it grew that fast, and we knew that there was going to be a problem. The other one that we talk about all the time is diabetes. There's another critical reason to take care of your health. It's way deadlier than we previously believed. The research offers evidence that 12% of deaths in the United States are caused by diabetes. 12%. That's the 3rd leading cause of death behind heart disease and cancer. And this is a lot higher than we used to think it was. It was put at 2.8% in 2010. Diabetes then was the 7th leading cause of death in 2013, and now it's the 3rd leading cause of death in 2017. The reason for the gap is that diabetes as the underlying cause of death has been underreported. That's because people die of heart attacks and cardiovascular things and high cholesterol and those kind of things. And we're looking for diabetes to be the cause of death, and they rarely die from diabetes. They die from a condition caused by diabetes, which is heart disease, stroke, kidney disease, or dementia. Diabetes as a cause of these conditions isn't often recorded, and we don't know about it. But more than 29 million people have diabetes, which is a disease in which blood sugar levels are above normal. And people with the disease either don't make enough insulin, which is a type 1 diabetic, and those kind of people have to take insulin the rest of their life, and they're born with that usually. Or type 2, which allows blood sugar to enter cells where it can be used for energy. When it doesn't have enough insulin or can't use it, the blood sugar builds up, damaging nerves and blood vessels. We used to have only insulin to create artificial insulin in your system, so we would add it to that. With people with diabetes, we can have drugs that stimulate more insulin production out of the pancreas. We can have drugs that cause the liver to metabolize sugar at a greater level. We can have medications that make cell sites more sensitive to insulin to be more effective. But this disease can really alter the quality of life in later years. And you need to take it seriously because it can affect your eyesight, it can affect your bone density, it can affect your circulation. Seeing a healthcare provider who will monitor your diabetes and help you learn to manage the disease, or an endocrinologist which specializes in diabetic care, an ophthalmologist or an optometrist that does eye examinations, a podiatrist that looks for foot care, and dietitians and diabetic educators who teach the skills of daily health management. Why a podiatrist? We talk about this almost every week. When you get diabetes and you get too much glucose, and it will accumulate in the inner linings of the cells and arteries. And so as those accumulate, the diameter of the blood vessel becomes smaller. And when you get an infection, when you get a blister, when you get a cut in the lower extremity, and you take an antibiotic, it takes it forever to get to that wound site and be effective. So we were talking about shorter stretches of antibiotics and not have to take them so many days. In a case where you have a vascular problem, meaning the venous flow and the arterial flow is compromised by something, then you need to worry about taking an antibiotic a longer period of time and taking it until that infection is cleared up, or it will cause you to possibly lose a limb. A lot of diabetics lose their legs to diabetes because they get gangrene from the blood being not able to circulate there, and the tissue becomes necrotic or dies. And as that tissue dies, they have to amputate the leg to keep it from going further. And then people do die from diabetes. So about 86 million people have pre-diabetes. That means you don't have diabetes yet, but the blood sugar level is higher than normal, but not high enough for type 2 diagnosis. Prevention is important so people don't develop the disease. So the research that has been done, most of the increase in type 2 diabetes is attributable to, guess what, obesity. The two are very clearly linked. It can be tackled through changes in personal behavior and public policies. We need to work harder to bring it under control. The CDC recognized lifestyle changes that offered a plan to a person online. You can find a weight loss program that works for you, and insurance companies are going to be requiring this. So step it up, gradually increase your physical activity. Any amount of exercise is better than none at all. And I know that's very difficult for some people to accept because they just don't like to exercise. But when it comes to a risk of dying or losing a limb, just start slowly by taking short walks. Use the stairs instead of the elevator. Walking briskly even helps your body use insulin better. You can gain about 6% loss in blood sugar level, up to 20% really if you're very active. So also that helps you reduce stress, improves your quality of sleep. The important thing about all this is to remember what we're saying here and start small and develop healthy habits that will last you a lifetime. Changing your lifestyle, as we've talked about so much, I hate to keep reporting it, is something that doesn't happen in one day or 1 week or 1 month. It's a continual thing that happens the rest of your life. And it even allows you to cheat. If if you're on an exercise plan, I swim every day in the summertime and when I can in the wintertime. And I always know when, and my physician will say, don't use this as an excuse to overeat. But I always know if I swim that mile a day, I can afford to have a piece of pizza, which I don't normally eat at all. Or I don't happen to be a sweet eater or a carbohydrate or a sausage sandwich or whatever it is to get by with it, which if I didn't exercise every day, I wouldn't be able to do that, and I would continue to gain weight. One last thing, drug overdoses. We talk about the opiate thing all the time. 1 in 4 drug overdoses are from heroin in this country. They're on the rise now. 1 in 4 of them are from heroin. The CDC found that 25% of all overdose deaths are from this drug, which is 3 times the proportion in 1999. Overall, the age-adjusted rate of drug overdoses is at 16.3 per 100,000. That's 2.5 times more than it was in 1999 when it was 6.1%. So several factors could affect that. So remember, that's a growing concern in the United States. We'd like to remind you we're North Lake Medical Pharmacy with 2 locations for you at 5136 Hill Road East across from Sutter Lakeside Hospital. Call us there at 263-6192 or outside the Bruno Shop Smart at 347 Lakeport Boulevard. Call us there at 263-1328. Thank you, Paul.
Thanks, Bill, and we'll see everybody back here again next Wednesday for Health Talk on AM 1270 and 96.5 FM KXPX Lakeport.